Dr. Fong, one of our listeners wants to know that she says she read recently that intake of probiotics makes immunotherapy less effective in cancer. Is this true?
Ooh, the area of probiotics and the microbiome are really a hot area of research right now. The thought is, with probiotics, you basically alter the bacteria that are in your body, including in your gut. And, there's emerging data that shows that depending on what types of bacteria are in your gut, that may actually alter your chances of responding to an immunotherapy. And as your listener points out, there also is some data that people who've received probiotics actually have a lower response rate. I think this information needs to be confirmed, and there needs to be more people studied in order to determine these effects. But I think in the meantime, since there's so much that we don't know about the probiotics and how best to modify the microbiome, I would recommend to your listeners, if they're interested in this type of an approach, to really do this in the context of a study, because sometimes, even though people might think probiotics as a whole might be a good thing, this is an example where it may not actually be a good thing, and we'd really want that to be formally studied and documented. And so again, my recommendation to the listeners would be, if you're interested in probiotics or changing your microbiome, to really try to participate in a study so that it can be looked at and there's a rationale behind what we're doing.
Thank you, Dr. Fong. The next question is, are there immunotherapies working for colon cancer that has metastasized to other organs? And if so, what are they?
Well, with regards to colon cancer, we now know that colon cancer can come in a few different flavors. And there's one flavor of colon cancer where there's alterations in the DNA repair mechanisms, and we call that MSI high colon cancer. For those individuals, we have an anti-PD-1 antibody that's FDA approved and has a very high response rate in the setting of colon cancer. Unfortunately, that's a minority of folks, and so the majority of folks will not have that mutation or alteration in their cancer. For the majority of folks that don't have MSI high, right now, this is a very active area of research with regards to immunotherapies, and so there are vaccine trials and bispecific trials and other trials that are going on in colorectal cancer, and so this would be something where we don't have the answer yet, but again, I would stay tuned as these newer approaches are underway and give us a sense of whether or not they're working for people who don't have MSI high colon cancer.
Okay, thank you, Dr. Fong. We have David with another question. Yes, David, please go ahead.
One more question, Dr. Fong. I've read a couple of your papers and a couple of the abstracts, and I know that a lot of your early work focused on prostate cancers. That's your natural field of interest. Well, my natural field of interest as a melanoma survivor is melanoma, and I'm curious how, kind of explain to the layman, how we can extrapolate the immunotherapy that you've been working on for over the years with prostate cancer, how we can extrapolate that into melanoma care.
Yeah, so melanoma and prostate cancer are very different cancers. As you're aware, melanoma arises in areas that often are sun exposed, and as a result, there's a lot of mutations that are there within that cancer. In contrast, prostate cancer actually has a very low number of mutations, and so as a result, the pool of targets that the immune system can see is actually less than it is in melanoma. And so, with regards to thinking about these two diseases, we really need to think about how the immune system is actually seeing these cancers on their own. And so, in this context, an immune system might be better able to see a melanoma rather than a prostate cancer. I think, the other component is we know that the prostate and prostate cancer are very immunosuppressive. And, this really creates a challenge. Even if you have an immune cell that can see the prostate cancer, when it gets to the cancers, when it gets to the tumors, it can unfortunately get shut down by a lot of different mechanisms besides PD-1. And, some of these mechanisms actually are more than likely also relevant in the context of melanomas, particularly those melanomas that are resistant to our existing immunotherapies. And so I think, this is where some of these observations that we can learn in prostate cancer may actually help guide us in other cancers that are more difficult to treat or are resistant to our immunotherapies. And, the hope is that some of these might be applicable to other difficult to treat cancers, such as, colorectal cancer, as we talked about as well. And so, this is, again, another very active area of research, and hopefully we'll get a better picture of that as we learn more.
Thank you, Dr. Fong. That was very interesting. Appreciate that.
Thank you, David. Dr. Fong, I've received quite a few questions people wanting to know the status of cancer immunotherapies in breast cancer.
Yeah, so breast cancer has been another disease that has been challenging with regards to the immunotherapies. And again, as we talked about in colorectal cancer, breast cancer actually comes in quite a few different flavors. As it turns out, we now have an approved therapy for breast cancer which combines an anti-PD-L1 antibody called atezolizumab with chemotherapy. And for women with that specific flavor of breast cancer, particularly if their breast tumors have this PD-L1 protein in the tumor, using this immunotherapy is now actually approved for that breast cancer. For other flavors of breast cancer, we do see some responses with these anti-PD-1 antibodies, but those rates of response are not very high. I think this is where a lot of interest in the field is thinking about combinations that could enable these immunotherapies to work. I think another area of excitement is actually using these immunotherapies earlier in breast cancer. And so in research that's actually pioneered at UCSF with Laura Esserman's group and the I-SPY program, immunotherapies have actually shown to have good activity when given prior to surgery for breast cancer. And so this would argue that perhaps giving immunotherapy earlier in breast cancer may actually also significantly improve response rates. And so now there are clinical trials that are focused specifically on that. And so that's another area that I think we should see a significant progress over the next few years.
Thank you, Dr. Fong. We just have time for 2 more questions, and then we can wrap up for today. The first one is there a movement to break out of the traditional data collection for clinical trials to allow for patients who might not qualify for a trial to try a drug without it corrupting our data set, thereby allowing for more experimentation? It's a long one.
Yeah, no, this is a very challenging question, and this really speaks to cancer not being one disease, but really, hundreds and thousands of different subtypes of cancer. And unfortunately, if you have a rare cancer or a rare variant of a cancer, you may not qualify for a clinical trial. And at this point in time, the way clinical trials are approved and run, we have to be able to define the specific patient population that we're treating on those trials. I think, the hope is that as we get more therapies approved and available within this, treatment toolkit that I alluded to, we may be able to customize treatment for people with rare cancers. But, at the present time, we don't have enough of an understanding to, help guide us in selecting treatment for many of the cancers. And unfortunately, the numbers of drugs that are now approved in that toolkit is still fairly limited. But, the hope is that as we really learn more about the different cancers and how they may be immunologically similar to others, I think that would really give us an opportunity to broaden out these immunotherapies to these rare tumors.
Thank you, Dr. Fong. The last question, and then it's a wrap for us today. The listener wants to know, aside from the scientific challenges, what are the top barriers in bringing cancer immunotherapies to patients?
Well, this is also a really big question. I think the barriers are many. I think part of it is access to these immunotherapies and clinical trials. A part of that is the cost, even for the approved immunotherapies, are quite substantial. That's also a very broad issue that is hard to address in 30 seconds. But I think this is something that immunotherapy in my mind is here to stay, and the hope is that even despite these barriers, it'll be available to more and more patients as we address these barriers.